Yeah, so I think we are happy to have multiple options for our patients with hepatocellular carcinoma that have shown tremendous efficacy. I think that it is leaves us with a little bit of maybe without clear guidance on the best first line regimen. Certainly, we know that the treatment for hepatocellular carcinoma is changing rapidly. The subsequent therapy options have expanded quickly, and many patients are getting immune therapy at least in the front line and sometimes even in later lines. And at the moment, we don't really have a clear understanding or data-driven understanding of the best way to sequence the options we have because things have moved so fast. We saw in CheckMate 9DW that the control arm, the TKI arm, did so much better than we had ever seen before with a median overall survival of 20 months. And so really that gives us an insight into the fact that patients are doing better than ever before, and subsequent therapy options are really influencing that. I think at the moment, I personally have a slight preference towards Atezolizumab, Bevacizumab in the first line setting for my patients. That is simply on the basis of a slightly better hazard ratio and also statistically significant improvement in progression-free survival. However, there's a lot of asterisks to that, a lot of caveats to that decision, and I think certainly folks argue other ways. There are many patients with hepatocellular carcinoma that are not candidates for VEGF inhibition, either with varices or significant cardiovascular disease, and that sometimes will lead me to choose an immunotherapy doublet and avoid Bevacizumab. But all things being equal, right now, I'm looking at Atezolizumab as my slightly preferred standard first-line regimen.